Assalamu alaikum and welcome to our second last module for the Hypertension Course 2021 organized by the Pakistan Society of Internal Medicine. My name is Zainab Samad. I am a professor of medicine and the chair of the Department of Medicine at the Aga Khan University. Prior to joining Aga Khan University, I was on faculty for several years at Duke University. I'm a trained cardiologist and hypertension is therefore very, very close to my heart. We are very lucky to have several esteemed colleagues presenting on today's module, and hopefully you'll all learn quite a bit today. Our chairperson today is Dr. Bikaram Devrajani, who is the Vice Chancellor for Liaquat University of Medical and Health Sciences. He is a prominent figure in non-communicable diseases in Pakistan, serving on several societies dedicated to the reduction of NCDs in Pakistan. He has several research papers and serves on multiple editorial boards for journals across the globe. Our speakers today are Dr. Umar Farooq and Dr. Jinhua Jiang. Dr. Umar Farooq is a nephrologist, a hypertension specialist, and associate professor of medicine, along with being the associate chief medical officer for Penn State Health, as well as the Penn State College of Medicine. He has a specific research interest in diabetic nephropathy and hypertension. He is going to be talking about renal artery denervation and baroreceptor modulation. Our next speaker is a very renowned person. She is Dr. Jinhua Jiang. She's a professor of medicine and works at the Beijing Hypertension League Institute in Beijing, China. She is the president of the World Hypertension League and a former WHO medical officer for NCDs. She's specialized in CVD epidemiology and primary health care. So a few housekeeping items before we get started. First of all, we're going to invite the first speaker. The speaker will flash their slide, and immediately after that, we will run a poll in which all participants are supposed to go ahead and take part of. After we run the poll, we'll show the results, and then the speaker will go ahead and finish get into their presentation. The same pre-test poll will be run at the end of the presentation as well. We will have our Q&A after the presentation. We'll also have some discussion from some of our esteemed panelists who are joining us today. So I would ask you, if you've got questions, to please put them in the Q&A box and or raise your hand at the end of the presentation. Thank you very much. Now I'm going to go ahead and ask our first speaker, Dr. Umar Farooq, to go ahead and start his presentation. Dr. Umar Farooq, after the first slide, we're going to do the poll, okay, just as a reminder.
Thank you, Professor Zainab. First of all, I would like to take this opportunity to thank all of you to provide me this honor and opportunity really to speak to our audience and really in the presence of my teacher. When I'm seeing my screen, I'm looking at the panelists, and I'm so happy and so fulfilled that I see the faces of my own teacher 2 decades ago, Dr. Tariq Wasim, Professor Azizur Rahman, Dr. Sajid Ubaidullah. So they were part of my core teaching team. And, decades later, when I look back, wherever I am, whoever I am, it's because of my teacher. So thank you for giving me this opportunity. So I will share my slides and then you can run the poll.
I'm going to go ahead and ask Dr. Umar Farooq to please get into his presentation and enlighten everybody on this very important topic.
Thank you. So today we will talk about the renal denervation and baroreceptor modulation, which are considered some of the advanced device-based therapies for blood pressure control. I will focus predominantly on renal denervation because that's where we have some randomized controlled trials. So these are some of my disclosures, and I just want to emphasize that the very important disclosure is this target BPI, which is a clinical trial. It's a randomized, blinded, sham-controlled trial by Ablative Solutions. And this is actually one of the renal denervation trials. So I am one of the site investigator or the principal investigator at Penn State. So typically what it works is like they have a blinded team, which is nephrologist and hypertension specialist. And there is an unblinded team, which is cardiologists who are actually, or interventional radiologists who do these procedures. So there is an other interesting story. So back in like roughly 8 or 10 years ago, when Simplicity team, they approached Penn State and asked us to participate in one of the, I think it was Simplicity 3 trials. And at that time, in our nephrology division, there was nobody who had certification in hypertension. So my chief, Dr. Brian Reeves, he asked me to just kind of, complete my certification. There used to be a society, American Society of Hypertension. So I actually completed the certification because of what happened with Simplicity. We did not participate in that trial, but a few years later, then I was approached to participate in this trial. So that's kind of my connection with this topic as well. I just wanted to make sure that our audience is aware. So let's look at the global burden of high blood pressure. This was a large study published in Lancet. I'm sure you might have seen this slide in the context. Burden is 1.4 billion worldwide, will increase to 1.6 billion in 2025. What I see and I'm really worried about is like, if you see the density, the color density, when you are seeing the red and orange and yellow, you know that those areas are heavily affected by high blood pressure, and the average blood pressure for these populations are high. And then colors which is green and blue is kind of really on the lower side of the color density. So Pakistan, the systolic blood pressure according to this study is 129, but you can see that Africa, Asia, and South America, a lot of areas are very red. And blood pressure is the single largest contributor to deaths worldwide. It's a silent killer, and it really leads to many other complications: stroke, heart attacks, heart failure, kidney failure. And the problem is, many patients don't know they have blood pressure, and many patients who treat blood pressure, it's not controlled. So this was one of the large meta-analysis, over 500,000 people from 123 studies. And it just showed that if you reduce the blood pressure by 10 millimeters of mercury, there is huge improvement and gains of outcomes. So cardiovascular events are 20%. So relative risk of cardiovascular events is 20% lower. Mortality goes down, heart disease, strokes, heart failure, renal failure, everything improves by just improving the systolic blood pressure by 10 millimeters of mercury. So, and this is from any starting point. So that's the important thing. So little improvement, larger results. But what happens in real life that despite of all these great data, the blood pressure control globally is suboptimal, and really 1/3 of treated blood patients with hypertension, you see their blood pressure is really controlled. So this really uncovers that the disease burden is very high. B, even when people are trying to control it, it's suboptimally controlled. And you can see that the incidence of the suboptimal control is more than 40% in South Asia, and across the world, it's 1/3 of the population. So within the hypertension, I know we are kind of towards the tail end of the hypertension course. So you have gone through a lot of definitions. Resistant hypertension is a tough case. So a blood pressure which remains above goal despite the use of 3 antihypertensives, and 1 should be a diuretic. And if somebody is on 4 or more drugs and blood pressure is controlled, this is called controlled resistant hypertension. So drug therapy is one, lifestyle modifications, one way to treat. Are there any device-based therapies, any other therapies? So baroreceptor modulations and renal denervation. There are some therapies which have come to fruition, especially there is a lot of work which is done in the renal denervation side. So if you, I'm sorry, I think yep. So the baroreceptor activation therapy, the concept is that these are the baroreceptors which are in the carotid sinuses. If this is stimulated, the signal goes to the brain, and then sympathetic activity is inhibited and parasympathetic activity is enhanced, which leads to decreased heart rate, vasodilation of the blood vessels, and more natriuresis in the kidneys and decreased renin excretion. So there are many observational studies with promising results, especially in the electrical baroreceptor activation therapy with this pulse generator implantable device. There are some endovascular baroreceptor amplification therapy devices and some transvenous carotid body ablation devices. But again, we don't have too many placebo-controlled trials in this, but the observational studies have shown promising results. So moving back to the other type, which is the renal denervation. So that is really tied into the autonomic nervous system as well. And this is the old diagram. I'm sure all of us are familiar from our anatomy atlas, which really talks about the parasympathetic and sympathetic nervous system. And you can see that kidneys are part of it. So really the kidneys are part of this two-way traffic. It's not one way, it's two-way traffic. So kidney, when receives the signal from the sympathetic nervous system, and this leads to more renin release, more RAS activation, more sodium retention, decreased renal flow, and some of the downstream effects. You can imagine that from the RAS activation and sodium retention, which leads to high blood pressure and other effects as well. Kidney also sends signal back to brain, and then brain actually, when the overall sympathetic activity is increased, it comes back to the kidney through the same pathway. It also goes to the heart, and heart leads to the effects like hypertrophy, arrhythmia. There is oxygen consumption that changes. It affects the sleep. So there are many sleep disturbances, and actually the denervation have been used as one of the therapy in obstructive sleep apnea. It leads to the vasoconstriction, atherosclerosis, and also insulin resistance. So many metabolic, hormonal, and pathological factors. So really two-way traffic. Kidneys receive this sympathetic drive, and kidneys send signal back to the sympathetic nervous system, and there is overall increase in the drive. How do we measure that? So there are methods, and especially those methods are predominantly used in the lab setting and in some of the studies, but then not in all the trials. So really the muscle sympathetic nerve activity can be measured. And then I think in one of the study, you can see that on the right-hand side of the screen, the presence of MSNA in controls, the healthy controls, you see that it's low level, then hypertension, it goes up, obesity, obstructive sleep apnea, congestive heart failure, metabolic syndromes, renal failure. So you can see that there is more drive for this adrenaline, noradrenaline, and you can check in muscle sympathetic nerve activity. And this is the skin sympathetic nerve activity, and you can see that it's not changed. So the probe has to be deeper in the muscle. It cannot be just done on the skin. Some of the studies used this, others did not. So the really, if you cut the tie for the sympathetic nervous system, so the concept is not new. The concept is actually quite old. There are papers published back in 1930s when progressive sympathectomy was done and it led to blood pressure control. There are papers that showed actually treatment for benign and malignant hypertension for 76 patients. And I think this paper was back in 1950s as well in British Journal of Surgery. There are paper, again, I think this paper is 1953, in American Medical Association, about use of splenectomy for the essential hypertension. The problem is, yes, it can control blood pressure, but the results are invariable. There is so much morbidity associated with this procedure. So some of our surgical colleagues who used to perform this procedure, they've told me that, you put these patients at risk of bowel and bladder dysfunction and severe orthostatic hypotension. So you've controlled one thing, but now you have replaced this one problem with too many host of other problems. So there need to be like more targeted therapy. So if you look at the anatomy of the renal nerves and how the sympathetic system is in the kidney, so the nerves arise from T10 to L2. They really arborize around the artery and primarily lie within the adventitia. So you can see, if you look at this picture, this side is the vessel lumen. Then, as you remember, like vessels have this, intima, media, adventitia. So this is the media, and this is the adventitia. And then you can see these renal autonomic nerves or sympathetic nerves, like really in the blood vessel wall, but around is this kind of the adventitia tissue, and outside of that is, of course, the outside of the vessel wall. So this is where the renal arteries lie, and the renal nerves lie, as you can see in this cartoon as well. So how do these procedures work? So I will show you, this is a old video, came with the original or the first generation devices. So really the catheter, so this is the same procedure as you do as if you are doing the heart catheterization. You go in the femoral artery, you go up in the iliacs, you enter the renal system, and then this is the radio frequency ablation. So catheter touches the inside of the wall and releases some energy, either in the form of radio frequency ablation or in the form of, there are some ultrasound devices which are giving ultrasounds as well. And this is controlled by the cooling system, so we don't burn the artery. So this was one of the, not simplistic, but this is one of the earlier first device, how they work. And there are the second generation devices are slightly different. So if you look at, as of now, there are three predominant renal denervation based therapies being used. The first one is the radio frequency based, and this is actually the first original trial, which was uni electrode. So this is a multi-electrode device, but the first one was like really the single electrode device, and the operator had to go through different spots. There was the mechanism as like where you actually go and do the radio frequency ablation. There are short-term safety, long-term safety. Efficacy in the short term has been proven, long-term we don't know. Then there are ultrasound-based renal denervation devices. So really, the devices go in same concept. You go inside the renal artery. There is like this, you use the wire, the balloon inflates, and then it delivers. And more recently is this alcohol-based devices, which is actually an infusion device. And this is the trial I'm currently participating. So really the radio frequency, ultrasound, and the alcohol-based. And the difference is this radio frequency, you are actually zapping different areas, but when you give the alcohol, the hope is that it really causes a very circumferential effect and maybe some fibrosis, so the nerve traffic is completely blocked. Whereas in the other therapies, there is a concern that sometimes the nerve traffic may not be completely blocked. So I will share some of the a pivotal trial done in this arena. So Simplicity Hypertension 2 trial. So there was a Simplicity Hypertension 1 as well, but this is Simplicity. I'm just presenting the Hypertension 2 trial because in this trial, there were 106 patients who either received renal denervation, RDN is the renal denervation, or they received medical therapy. Their blood pressure was very high, more than 160 millimeter of mercury at baseline. And this was followed for 6 months. At 6 months, the 37 of the control were actually crossed over to the renal denervation arm. And then there was further data all the way up to 12 to 36 months. So you can see that patients had uncontrolled hypertension, blood pressure more than 160. They were in the 2 weeks observation period. And then they had their anatomical, screening, MRI, CTA, duplex angiogram done. They were randomized. Control group, this is the treatment group. And then again, I think they took some patients from the control group back into the treatment group. And the results were astronomically very, very impressive. The blood pressure reduction, systolic was 30, diastolic was 12. So this led to the larger Simplicity. Okay, so these are the results. So you can see that office blood pressure improved by 32, systolic in the renal denervation and control, there was not much difference. So the complications, 1 hematoma, there was 1 renal artery dissection before energy delivery that was treated successfully. Later complications, 2 cases of acute kidney injury, which eventually resolved, and 15 patients required hospitalization, and there were 3 deaths reported in this study as well. So then the Simplicity Hypertension 3 trial was done. This was very large, prospective, single-blinded, randomized, sham-controlled trial. In previous one, they were actually doing a procedure, renal denervation, and compare with the medication. In the sham control, what you do is that you bring the patient to the angiography suite as if this patient is going through the procedure, and you do everything, but you don't do the procedure. So, so this was, and that actually, the trial design was different than the previous trial. So there were more than 500 patients, blood pressure more than 160s in the office, and the 24-hour ambulatory blood pressure was more than 135. And when they looked at the results, so this is really at the 6 months follow-up, there was improvement in the treatment arm by 14 millimeter of mercury in the office, and 7 in the 24-hour ambulatory blood pressure. But then in the sham arm, or in the control arm, there was also improvement of 12 and 5. So the difference between the 2 arms was not statistically significant. So this very large international trial actually turned out to be a negative trial, that whether you do the procedure or you don't do the procedure, the results were similar. So there are many explanations, discussions about what happened, why we saw great results in the beginning, and now we are not seeing good results. Some of the explanations which I found were the medication. There were too many medication changes during the trial. So 40% of the patient, the medication were adjusted. So maybe the good effects in the control arm was actually from the medication adjustment. Maybe patients were not taking their medication. So now, as a part of study, they were actually very compliant with all their medication. There was variability and inadequacy in the operator experience, which actually they tried to measure, but it was too late. And then the renal denervation they thought might be inadequate, because in this large trial, they did not actually do any lab testing of the nerve activity testing. So for a while, the renal denervation was kind of, lost the charm, but then the folks got together. So there was this second, the European Clinical Consensus Conference back in 2017. So they came up with, some recommendation. So maybe the patient population should be more homogeneous. The targets should be reasonable, not 30 and 40 millimeter of mercury, but maybe 6 for, they said, like, if you shoot for 6 for ambulatory blood pressure and 10 for office-based blood pressure. Primary endpoint should be the ambulatory blood pressure monitoring. And the control and the need for sham control was identified, that this should be part of future trials. And also, I think they'd like to address the concept of this off drug versus on drug, like whether this therapy is the isolated therapy without any medication, or you actually use this as an additional therapy on top of somebody taking the medication. So you lower their blood pressure or maybe reduce the number of the medications they take. And also there are next generation of the RDS devices as well. So there was focus about this consistent denervation treatment. So reduce the variability, more standardized trial. I know in every presentation, there has to be a slide which nobody can read. And this is one of the slides. These are the list of, and I don't want you to read it. These are the list of randomized trial for catheter-based renal denervation system. Some are large, some are small. And then on the right-hand side, there are real-world registries as well, and some non-randomized trials. So you can see that there are many groups across the world trying to get a handle on it. And there was another page as well, which I didn't take in this picture. So I would present very quickly the results for 3 very pivotal trial. One is spiral hypertension off medication, which means, like, you do the therapy without medication. One is the spiral hypertension on medication. It's a proof of concept randomized trial, and radiance hypertension solo. So this is the first trial after simplicity, which I would like to present, is the spiral hypertension off med spiral pivotal trial. 331 patients, renal denervation versus sham, not on medication, off med. Office blood pressure more than 150 to 180, diastolic blood pressure more than 90, and ambulatory blood pressure between 140 and 170. So at 3 months, the difference, and this is for the 24-hour systolic blood pressure, was 4. And the office blood pressure difference was 6 between 2 groups. So there were no major device related or procedure related safety events. So positive trial with the sham control, and the effect was up to 4 and 6. Spiral hypertension on med trial, 80 patients, renal denervation versus sham. So these patients were on 1 to 3 medication, and there was a run-in period where you actually titrate the medication. And these patients were on stable doses for 6 weeks. So for the preceding 6 weeks, no change, stable dose. Office blood pressure between 150 to 180, diastolic blood pressure more than 90, 24-hour ambulatory blood pressure 140 to 170. So really targeting somebody with very high blood pressure despite of taking these medication. And again, showed good results. So and these results are at 6 months. So the effect was really in the 24-hour, really 7 millimeter of mercury difference between the treatment and sham. And then really a positive study for both groups at 6 months as well. So another trial, again, large trial, radiance hypertension solo. This was off meds. So multi-center, again, international single-minded, blood pressure 135 over 85 to 107. Actually, looks like might be a typo, over 105, and off medication. And again, showed positive result of 8.5 millimeter of mercury between the 2 groups in the ambulatory and in the office blood pressure, and no major adverse events were reported in this one. So putting all of this together, so summarizing these 3 trials, So spiral hypertension, off med, on med, and radiance hypertension solo, you can see that there was a follow-up for 3 months, 6 months, and 2 months in this one. There were 35 patients in the spiral off med, 36 patient in on med, and 74 patient in radiant hypertension solo. And you can see the change in the systolic blood pressure. The blue is office, the orange is 24-hour ambulatory. So you saw a good improvement by 10 millimeter of mercury in the office blood pressure and 5.5 in the 24-hour ambulatory. And then the similar results. You can see that spiral on med, the result is 9.4 and 9, and radiance hypertension solo 10.8 and 7. So the three results are kind of matching. So the Simplicity 3 trial was a negative trial, but then these follow-up trials, which were done with probably better trial design and the future or the second generation devices, showed good results. So this brought, I think, the renal denervation back into the limelight as well. So this is a meta-analysis. Again, I think I gave you the 3 trials, but this is a meta-analysis for 6 sham controlled trials. This is published 2019 in American College of Cardiology Journal. And really the roughly 1,000 patient, 6 trials, 582 patients were randomized to renal denervation, 395 to sham. And there were 3 second generation trials. And you can see that the mean patient age is 52 to 64, median follow-up is 2 to 6 months. And it showed, like if you see on the left hand for the meta-analysis, you can see that the favoring of renal denervation is kind of across the board, except the Simplicity Hypertension 3. So really the 24-hour blood pressure reduction was 3.65 millimeter of mercury. With the second generation, it was roughly close to 4. And office blood pressure reduction is 5.5. And in the second generation devices, 7 millimeter of mercury. And rare adverse events associated with these, especially with the newer trials. So moving forward, this was the third kind of device category, which uses the alcohol-based device. So what the actual device is, you go inside the renal artery. You can see in the right lower corner, you can see the picture. So the device actually comes out, it pierces from the inside of the vessel to the outside, and then it doesn't go through and through, then it reaches to a certain distance and then injects the alcohol. So it causes more like a circumferential fibrotic pattern or whatever the site of activity is. So this was their first initial trial, which was multi-center open label trial. And this was the first trial to evaluate really safety and efficacy of this system and this device and the alcohol. And 45 patients were in this trial. They were on more than 3 blood pressure medication. And actually it showed similar results. So there was improvement of 24-hour blood pressure to 11, and I think the office blood pressure by 18. So from this open label trial, right now, the current trial, which I'm also participating, is ongoing for the target BPI off med and target BPI I. I'm part of the second trial. So more to follow on this. We have not, again, we don't have any results for this, but this is where the current trials are going. And this is really recently published in Nature about the timeline of some of the trials. As you could see that the development and approval of any device, it takes time, trials, maybe failure. Sometimes you consider failure as a pathway to success or a part of success, not just failure is just not a failure. So you can see the Simplicity Hypertension trial 1, 2, 3. More recently, now we are in this radiance hypertension, solo spiral hypertension on med, and there are now global registries as well. So just to kind of focus that there are a lot of work being done for device-based therapies to control the resistant hypertension. So coming towards the end, the hypertension is the most prevalent modifiable risk factor, and it leads to a lot of cardiovascular morbidity and mortality. Renal sympathetic denervation is the most extensively investigated device-based therapy for hypertension. And there are trials for both sham controlled, proof of concept, and really we are moving forward. As you can see that the three systems, one is the radio frequency based renal denervation, ultrasound-based renal denervation, and alcohol-based renal denervation. These are the three major kinds of devices and trials which are kind of in progress. Right now, these devices are not available for routine clinical use. So really these devices are either you're enrolling your patient in the trial, and really we are waiting for the science to declare itself, and these devices are available for the clinical use. But there is hope, and in the end, I would like to share my journey. This is my alma mater, and I can see that some of my colleagues sitting in the panel room, and I'm sure we have 204 participants. So some of you might really recognize with this photo very, very easily. Then I came to University of Pittsburgh. This was the hospital where I did my residency. It's in one of the UPMC hospital in Pittsburgh. And this is my current place where I came back for nephrology fellowship back in 2008. And I have been here since that time as faculty, have gone through over a decade now as faculty. And again, I feel very blessed, happy, honored that our speaker panels and hosts, they gave me this opportunity to talk to all of you. Thank you very much.
Dr. Omar Farooq, thank you for that fantastic talk and reviewing such a large body of evidence on an up-and-coming treatment for resistant hypertension. I'm going to ask the IT team to run the poll again. So the participants should go ahead and participate when that thing's put up. All right, fantastic. So we are done with the post-test polls. And while our IT team collates the pre and post comparison, we're going to go ahead and get some questions answered. So we actually are very delighted to have a set of very prominent cardiologists and physicians who are bent on fighting the non-communicable diseases epidemic in Pakistan here with us. So I'm going to ask some to comment directly and ask questions in the talk. But before we go ahead and do that, we have some participants who got questions. I'm going to ask Dr. Waqas Ahmed Jan to ask his question now. Dr. Waqas Ahmed Jan, go ahead and ask your question now.
I think IT department has to unmute him.
Yes, yes, I think IT did. Yes, he has been unmuted. But he may not be able to do that for some reason. So I think what we'll do is go ahead and get our panelists to weigh in. I'm going to ask Dr. Shehbaz Qureshi, who is a very prominent cardiologist in Pakistan and who knows the value of hypertension control and the issues that we have country, to please make a few comments. Dr. Shehbaz, you have to unmute yourself.
Yes. Thank you very much, Dr. Zainab. And I think Dr. Omar Farooq gave an excellent presentation on renal denervation as far as the management of resistant hypertension is concerned. There are a few things, I think, which one needs to actually emphasize in this regard. First of all, we have to diagnose resistant hypertension. And it is not merely that the patient is taking 3 drugs and one of them is a diuretic and is resistant to hypertension. What we really need to do perhaps is to do an ambulatory blood pressure monitoring in these patients to be able to ascertain whether this patient really has resistant hypertension or not. And secondly, is the value of adherence, which is extremely important. And we have to see whether the patients are adhering to their therapy or not. And if they are adhering and still the blood pressure is high, then obviously you have the device therapy, which is there for these patients. So adherence is extremely important. And before that, even lifestyle modification, that is very important. Now, when we talk about renal denervation, as Dr. Omar Farooq rightly pointed out, it is the sympathetic system which is to be affected. For example, this was what was done in 1930s and 50s when there was the surgeons used to do a sympathectomy and then reduce the blood pressure, and then came the drugs, and then you started treating them with drugs, which was more important. When we talk about the sympathetic nervous system, it brings back the beta blockers into contention. And I think this is also very important because beta blockers also affect the sympathetic system. Then in the Simplicity Trial 3, it was basically, I think, the procedure which was not properly done. The training of the different centers was not at the same level, as a result of which we did not see the good results. And now with the pivotal trial, what you are seeing is because of it's a randomized effect with a placebo, with a sham control there, and then with the medications, the results are better. But what is to be appreciated is that these results are for 3 to 6 months. What happens after that? There's a regrowth of the efferent fibers. And if that occurs, the sympathetic nervous system comes back into action, and therefore the blood pressure will start rising again. So it may not be a long-term effect. So the most important thing is that we should emphasize that the patient should adhere to the treatment so that they do not become resistant. And there's a group of patients, like for example, the isolated systolic hypertensive patients, they have not responded to renal denervation. That also should be seen. So it's a particular phenotype which has to be identified, which will be amenable to renal denervation. So I think there are a number of questions which need to be answered. The long-term results have to be seen as far as the renal denervation is concerned. And it is not the panacea. It perhaps brings down the blood pressure in 30 to 40% of the cases. So drug treatment is definitely has the place, and it should be continued, and adherence should be emphasized. This is extremely important. And in our country, for example, what we really need to do is a very simple measures. Reduce the salt intake. Make sure that the patients don't take it because we are sensitive to salt. And that may be the reason that you are resistant to it. So I think there are a lot of questions which still need to be answered as far as renal denervation is concerned.
Thank you, Dr. Shahbaz Qureshi. That was a really great summary and comments. I'm going to ask Professor Tariq Wasim to make a few comments, please.
Oh, thank you, Zainab. The first thing is that this therapy, probably for the general audience, as already mentioned, is not available for public use yet. It is in trials and it is being studied, and it probably would be may not even see the daylight. I may say it. The second thing is that what I want to ask you from Omar is that has there been any gender or ethnic based differences in response to this therapy in their studies, or is it black and white and around everyone responding in similar fashion? So may I ask Umar to comment on that?
So I have to go back and look at the specific answer, but I think it's the ethnicity wise, it's an international study. So there are like 40 plus, 50 plus countries involved in one or some of these trials as well. So I think it's probably, I don't think I can answer your question right now, but certainly, if there is a subgroup analysis or not,
Because
I can get back to you on this.
we do think that
I think
the black are usually have more of a resistant hypertension, and maybe there may be some difference in sympathetic responses, ethnic-based difference other than. So that might be something which we interest someone.
I think basically the ethnicity variation or the gender variation has not been seen. It is those individuals, like for example, you have individuals with an isolated systolic hypertension, they don't respond to it so well. And those with high cardiovascular risk and resistant hypertension, they are the ones who have been responding to it, whether it's a male or a female. But there has been no analysis in any of the trials as to the subgroups of ethnicity or the gender. And then you see, because as Dr. Umar said, it was a multinational study and the expertise available at the different centers is different. And therefore, I think it was not a uniform kind of a study.
I agree.
Thank
I think
you.
the only thing I saw was that isolated systolic hypertension, and I did not see any other, analyses done in a way as the question is asked.
And
Thank you very much, Dr. Tariq and Dr. Qureshi. I'm gonna. Do you have another question? I was going to move to Dr. Bilal, who's got his hand up
just
for a while now.
one. What is the number? I mean, the difference between the treated and non-treated group was very, very small. It's 5-7 millimeter of mercury, and we are talking of a resistant hypertension. We usually have blood pressure in the regions of 220 over 120 or something. So would that 5 millimeter, although we did show that 10 millimeter mercury is a lot of difference as a cardiovascular mercury. So this small difference with the, say, interventional procedures, so is it worth it?
Yeah, I think jury is out there. Is the juice worth squeeze? You put patients at risk of invasive procedure, and that's what I think happened with the original trials. The first trial showed huge magnitude of difference, and the subsequent trials did not actually carry that kind of difference. So really, the renal denervation therapy has to find its place in the overall schema of the blood pressure treatment. And you're right. If I'm a patient and I know that I will only get 5 or 10 millimeter of mercury benefit, I would kind of think twice.
Yeah, and I think
but
earlier, Dr.
Would you agree that even a 10 millimeter decrease in blood pressure result in all the meta-analysis which have been done, a very significant reduction in the incidence of myocardial infarction, cardiovascular events, stroke, and all these endpoints? I think that even a 10, but when you have a blood pressure of 220 by 120, that perhaps is not in the definition only of resistant hypertension. That is different.
Right.
I do have an answer.
Yes.
I think like a comment, Dr. Qureshi. I think you're spot on. Two types of patients. So if I don't want to take more medication, I want to slow down. I'm not really good at taking pills. I would rather take this device therapy and be done with it. But if I'm good at it, maybe take like one or two more. So compliance, I think you hit that point very hard in the beginning. The compliance is the number one important thing which we can, really, that's the best intervention. So again, I see our next speaker is here. So maybe I should stay quiet now.
Thank you. Thank you, Dr. Umar Farooq. I think Dr. Qureshi kind of hit the nail on the head by saying this is not the panacea for hypertension control. And really, it should be diagnosis and ensuring medication compliance. I have one more panelist who would like to make a comment. And then we have poll comparisons to show you. So Dr. Bilal Muhyiddin, please go ahead and make your comment.
I will go over. Thank you, Zainab. I have a couple of questions and a few comments. It's quite an interesting situation in which we are currently. Yes, these devices are not as such available for anything outside trial, but somehow they are being marketed. And I have been offered a couple of these radio frequency older models. So I really don't know which answer is the correct one. as far as the yes and the no part over there is, because they are being marketed at the moment. Anyway, two questions that are, and then a comment for everyone to participate in. Two questions. So when you're doing your alcohol ablation, which alcohol, what concentration are you using? And then when you're using this alcohol sort of went out of fashion, especially for varicose problems because of the esophageal strictures that it was causing. And what do you foresee? How many strictures, and then how many renal artery stenosis and then stenting are we going to end up with? So that is one part. And one thing I'd really be interested to understand is when you do this sham control trial, how do you maintain the secrecy? Because someone in the lab knows it's a sham going on. And when the patient finds out, how is the blindness is going to be maintained? So these are the first two questions. And the comment that I sort of had was that, this whole story about internationally that we are listening to constantly is that only 10% of or 5% of Pakistani population who are being treated are well controlled, and internationally so many less. Let us also nail it hard over here, because I think we are to be blamed. And in another angle also now, when we come up and say that you get your pressures down by 15, 20, 10 millimeters, this is the kind of benefits you're going to get. In those graphs, they never say that if you achieve the target, so they will say that you got it down by 20 and this is the advantage that you're gaining, but what is the final benefit if you're really able to achieve the target? So many a times, the message that actually goes out to a lot of these patients, and I'm working on it these days, is that they have a feeling that, okay, even if you're able to get it down by 10 or 20, that is good enough. My risk factor has gone down by 50%. So they don't really understand to what level they actually can take it down. And that is probably where we are, to be blamed. Other questions were regarding the arterial stenosis, so I think that will be discussed later on. So what is your take on sham, etc.?
Thank you, Dr. Muhyiddin. I'm just going to go ahead, Dr. Farooq, if you want to mind answering those questions, and then we'll have to show poll comparisons.
Sure, I will quickly address some of those questions, or I can answer others, or jury is out. So the alcohol, you're right. So it was kind of a good sclerosing agent. It was fashionable, then it lost its charm. It's coming back in this. So the dose and the concentration, I don't recall on top of my head what concentration they are using, but it's not. I remember it's not very concentrated. I think what they have done in the lab is they have done a dose response curve analysis on the animal model as how much alcohol to inject at what kind of distance between the three spots, and how deep the device actually. It's really the infusion device that goes inside the vessel wall and inject. So in the first trial, there were not many issues with that renal artery stenosis or the fibrotic, but long term we don't know. It's a new thing. So we have enough experience of 6 months, a year, or 2 years to report back to you. But in the phase 1 or the initial trial, they didn't see any of those major problems, because they have done enough animal testing for the efficacy and for the safety first, and now they're doing the efficacy trial. The answer to the second question, I think jury's out there. I think, again, this is one treatment modality. It has to find its place in the large scheme of things. But for some patients, this may be beneficial. And for others, we still have to focus on the population-based blood pressure control and the pharmaceutical medication. Big blood pressure is epidemic, it's pandemic, I think I would say. And really the population-based approaches, I know about my colleague in the follow-up session is talking about really the population health aspect of blood pressure control. I'm a big believer in that, but certainly, I presented the evidence, I presented the data as it is. So I hope that we get better and more data in the future years.
Thank you, Dr. Farooq. I'm going to ask the IT team to go ahead and show the poll comparisons, please, right now. And maybe you can make some comments if you see any things to point out to the audience at this point. Feel free to make comments as the slides proceed.
Yeah, so you can see that the understanding of at least the standard definition of resistant hypertension improved from 78% to 91%. So there's a positive change. So thank you, audience. Good job. I think it's okay if you did not get this question right. This was kind of one of those trick questions. But at least, more than half of the people remembered that it's in the adventitia. So again, I think there is positive improvement. So you can see that there is improvement. I was hoping that, my message was through and through, but it did not reach to more than 50%. So actually, this was a negative trial. Again, I think this was the vague question because jury is out there. So I think I just wanted to make sure that people know that this is what's the current active use for these devices. It's in the research trial and specialized centers, not clinically openly available. Unless I know Dr. Bilal has some special, he got some special marketer reach out to him.
Well, basically, it was all about, probably could be based on trial or something like that. But then they are marketing it, and it's Medtronic who is trying to push it out.
Yeah, Medtronic has the device.
Yeah. So they are pushing it out, and but again, being marketed over here, of course, does not mean that it's being marketed in USA. Remember that a lot of things get marketed in Europe and Asian countries far before USA even knows
we
the
are
spelling
far
of
behind.
words. Yeah.
We are so far behind in some of those things because of the regulations and IRB and FDA and all that. So,
but then we take the music basically first.
Thank you very much. I think there was improvement in the post-test polls, and thank you for clarifying many of those important points, Dr. Farooq. Again, it was a delightful talk and really a great summary of the evidence out there. Our next speaker I'm going to call on is...
Zanab, just a small, quick question for him. Though he did not discuss about it, but his topic covered that he'll be discussing a little bit about renal artery stenosis. My just simple question was that if you have got bilateral renal artery stenosis, should we touch it together?
Can we address this question towards the end of the next speaker?
Yeah.
So again, really excited to host Dr. Xinhua Zhang from the Beijing Hypertension League Institute. She's a professor of medicine and the president of the World Hypertension League. She's a former WHO medical officer for NCDs and specializes in cardiovascular disease epidemiology and primary health care. Dr. Xinhua Zhang is going to be talking about speed up, scale up of hypertension control in low middle income countries. And we're so honored to have you on board with us and sharing your time with us today. Dr. Zhang, I'm going to ask you to go ahead and show your first slide. And after the first slide is up, we will put up the poll questions. And once the poll's done, then you can go ahead and get into the presentation.
Thank you. Here is a topic of my talk, the scale up the speed up hypertension control globally, specifically in low middle income countries.
The poll IT team can go ahead and put up the poll questions now. All right, fantastic. I must say, Dr. Zhang, those are some excellent questions. And the participants have voted. Please go ahead and share your insights with us now.
Thank you, Dr. Chairs and organizations, and also distinguished experts, and specifically thanks to coordination of Dr. Sonia. It's my great pleasure to join this important training course. And the answers and the discussions after the first speaker is very, very good, and show the importance and also the necessity of this training course. I'm so pleased and honored to be this part. And the previous doctor already, presented how big a burden and how important of hypertension in the disease, the death, and the disability. Here is the statistics we can see. Every year, there's more than 11 million deaths globally attributable to hypertension. So it's the first leading cause of death for women and the second leading cause after the tobacco deaths for the men. So totally 11 million deaths globally in 2019, and the increase because the age population. And also it's not only cause death, but cause many disabilities for those survived from the hypertension related coronary heart disease or stroke. Most of them cannot get back to their previous ability in working and living. We can also see that 9% of total disability adjusted life years globally attributable to hypertension. So it's very important and preventable and controllable risk factors globally, no matter in which geographical region or at what level of economic situations. So it's everyone's business, and the whole medical society is concerned. So thanks to Pakistan Society of Internal Medicine to organize the specific training for hypertension control. From the large population studies, we know that every level of increase of systolic blood pressure in every age group, from the middle young age group to the old age groups, whenever the systolic blood pressure increase, the mortality log linearly increased with coronary heart disease and more in stroke. So if we can reduce just 20 mmHg for systolic blood pressure for adults, we can reduce 31% of coronary deaths in old age group and 48% of coronary deaths in younger age group. And this percentage is larger for stroke. And we can say the 33% of stroke mortality will be decreased by 20 mmHg of systolic blood pressure decrease, and 64% of deaths from stroke can be reduced. So only 20 mmHg systolic blood pressure could halve the risk of CVD mortality. Just think about 11 million of deaths globally every year. If we can reduce the systolic blood pressure, specifically for those at a very high level, if we can move forward to left side, then we can save millions of lives, to keep more families happy, and the situation is getting better, and economics development. So we know how to reduce the blood pressure, although it's hard, and it's hard to many people, but most of them not that hard, because the evidence-based, cost-effective treatment options for hypertension do exist globally. But we need to scale up the control strategies. We know how to do it, but we need to cover all of the patients, to cover all of the population, to provide, make them available, accessible, affordable, and quality assured to all the populations, no matter where you live. Your hypertension need to be detected, to be diagnosed, treated, and controlled to the goal. We also need to speed up this process, because every year millions of people die from hypertension-related diseases. So as soon as possible, if we can approve the hypertension control, we can save more lives. So we need to active government, active health professionals and health systems to work coordinated, integrated for the same goal to control hypertension. And also, as hypertension is the largest number of patients population and affect almost every family. So the system, if it works for hypertension, it may work for all non-communicable disease. This is very important to work first for the largest cause of death and build up the system and can be used for all other non-communicable disease control. And by the end, we need to implement the best practice in primary care settings because the huge amount of patients, so we can't only rely on our professional experts groups and large hospitals. So that's not enough. We need to implement the best practice in primary care settings to get most people have the accessible and available care. So here is the current situation. We know how simple to detect hypertension, but we still among the 1.4 billion hypertension patients globally, only about half be detected, means half of them never getting chance to measure the blood pressure and they don't know they have it. So it's not aware of the situation. And about a third get treated. So the treatment is available and have mountains of evidence to prove it's effective, but most of people still not getting the treatment. And sadly, every less than 1 in 7 with hypertension worldwide have it under control, which means less than 14% of 1.4 billion hypertension patients getting controlled. So this is a serious problem. And the situation even much worse in Africa. There, specifically in South Sub-Saharan part Africa regions, those aged 25 years and older, nearly 1/3 or half of the population have hypertension, and only less than a third know their situation, and only 18% get treated, and the control rate is only half of the global average. So the situation is much more needed, and also the similar situation for other countries with the, the limited resources. Here's an example of hypertension control trends in China. We know most of them are not covered for the detection, for diagnosis, for treatment, and for the control. But even if we improved, but we need to improve quickly. For example, in China, the prevalence increase, we know that we can't reduce the prevalence because when you treat it, this keep survive longer and you have more patient in the population. So the prevalence increased globally, but if we prevent effectively, it can increase the slower and less, but you can't reduce it. But awareness, treatment, and then control largely depend on the health services. So we can see from the experience in China, every 10 years, the awareness improved substantially, and the treatment improved, and the control rate improved. By beginning of this decade, it's already doubled from previous decade. We can see it improved substantially, but still the prevention, the control, awareness, treatment, and the control rate is far less than developed and high income countries. So we need to speed up. So we not only need to coverage, more people get detected, get treated, get controlled, but also we need to speed up the process to improve faster and get more people can be quickly get controlled. But we all know how, even we know it's the strategies, the techniques, the drugs, and we know most of the measures to control hypertension, but still have a lot of hurdles to overcome to achieve the blood pressure control. We have a lot of hurdles in diagnosis. For example, not many people get screened, not getting diagnosed, and the low attendance for the screening programs, or not low attendance for clinical to attend the screening, and inaccurate measurement, either invalidated devices or the incorrect procedures for measure blood pressure. And we also have the problem in treatment with no protocol. So we cannot get it more efficiently and simple and can be applied to many people. And we can get non-physicians to help because we do not have the protocol in most of the places. And the drug shortage, you do not have enough drugs to cover all the diagnosed patient, and the therapeutic inertia for the doctors and not change, not adjusted, not titration the treatment according to the patient's blood pressure changes, and also the involvement in the private sector and the patient flow not followed. And also for the continual care, because we need to diagnose, treat, and also need to lifelong time to continue the care. Because no reminders, no recall system, most patients have lost the follow-up, and also sometimes medication not affordable, even they know they should come and it's too expensive for them, and no information system to recording the performance and also the result from these care services, and the low adherence, the patient are not complying to the treatment at all. So all these important hurdles needed to overcome for the improved hypertension control globally. So the World Health Organization work with all their partners, including US CDC, World Hypertension League, International Society of Hypertension, and all many other partners to work together to develop this HAS technical package. Has 6 characters and 6 letters, including 6 very important key components: the health lifestyle counseling and patient self-management advice, evidence-based treatment protocol, access to essential medicine, the technology, risk-based safety management, team-based care system for monitoring. Among all these 6 components, the most efficient and the most important things to added to all of the hypertension control systems is evidence-based treatment protocols and also system for monitoring. And then very importantly, and unlike other programs developed by World Health Organization for the HAS technical package, every component have their specific protocols and the training courses and the strategies and the policy supporting, and also gave the implementation guide, even how to develop a specific protocol for each specific areas. So this provided a very good and very important tools to help the primary health care to improve the management of cardiovascular disease and risk factors. Currently, we focus on hypertension and also including diabetes and others later on. So here is the examples provided by World Health Organization about evidence-based standard treatment algorithm. It can be any first line. You can start from any first line agents, for example, thiazide-like agents, ACEIs, ARBs, long-acting dehydropyridine, CCBs, or the single pill combination and any other two, combined together. So you can start from 3 large classes, and for those already have the, the coronary heart disease, beta blockers should be the first lines also. So it's basically a stepwise titration, the algorithm. So one by one, you can add on. So this is very simple and very important protocols. We will have primary care, specifically for non-specialists to treat hypertension more efficiently. We have a very successful example from North California case of permanent residence. So they can do, in 10 years, they increase the hypertension control from 40% to 90% with the cheapest drugs and simple procedures. So this is a very good and successful example. So that's why the WHO implemented and also recommend this very important algorithms. So for the HAS technical packages, WHO HAS package they gave the threshold for initiation of treatment of hypertension. So within the evidence-based treatment protocol, or we call it the algorithm, the threshold for initial treatment for those without chronic disease or without high risk or without diabetes, chronic kidney disease, or existing heart disease, stroke. So for most of the patients, the threshold for initiation of treatment is systolic blood pressure greater or equal to 140 millimeter mercury, for diastolic blood pressure greater or equal to 90 millimeter mercury. For those on the antihypertensive treatment, no matter what blood pressure levels, they should be initiated whenever they start the register in the heart projects. And for those already have diabetes or chronic kidney disease or at a high risk of cardiovascular disease, their threshold will be 130 mercury for systolic blood pressure. And for patients with existing heart disease, stroke, it's also 130 mercury. So when they reach the threshold, they should be initiating treatment. And here are the targets. So for those without complications, the systolic blood pressure should less than 140, diastolic blood pressure should less than 90 mercury for all adults. But for those with high risk or with diabetes, chronic kidney disease, should less than 130 for systolic blood pressure. And for those with existing heart disease or stroke, should also less than 130 mercury. That is the target for blood pressure control for the evidence-based protocols, and also the protocol set up the frequency of assessment. So it needs to be 4 weeks for patient's blood pressure, not control to target. And for the patient, you need to prescribe the medicine for 4 weeks, not only 1, 2 weeks. And if it comes too frequent and we do not have enough manpower to control so many, to manage so many patients, and also the patient's blood pressure have not achieved the drug, achieve the maximum efficient. So for those not controlled to target, they should be assessed every 4 weeks. But for those already controlled to target for at least 2 consecutive visits, then we can prescribe the 3 months medicine for the hypertension. So we can prolong the assessment frequency and make less trouble for the patients and less burden for the healthcare services. Here's an example of standard algorithm for treatment hypertension in primary care settings, and this example comes from the Heart China Hypertension Control Project in one province. This province has 100 million population with 2,000 primary care services. So we can see the algorithm, the first step is to screening. So we measure blood pressure for every adult who are older than 18 years old visiting the clinic for any reason. We are going to measure blood pressure. If it's reach the threshold of treatment, and for those without any other complications, so if over 140/90, we are started the treatment to prescribe amlodipine for 5 mmHg. But if they have diabetes, other problems, they can lower to 130/80, start the treatment. But if after 4 weeks, they come back for reassessment, if it's still not controlled, then they check if the patients follow doctor's advice, take the medication properly. If yes, we increase to double the dosage, and reassess in another 4 weeks. If blood pressure is still not controlled, we still check if they follow doctor's advice and take the medication and dosage properly. If yes, we add ARB. Here is a temsatan for 40 mmHg. And again, we evaluated for another 4 weeks. So with this same way, the visiting frequency every 4 weeks, the initiated treatment threshold 140/90 for normal people and for 130 for the patient with diabetes, chronic kidney disease, or heart disease or stroke. And with this stepwise titration, we can step by step getting most of people get controlled. And if after we end the diuretic, this here is in that mind, 2.4 millimercury for 4 weeks. If still not controlled, then we can refer the patients to the specialist in hospitals. So here is an example, applying the WHO algorithm with the local available, high quality and affordable medications. So with this practically implementable, detailed, the algorithm and posted in every doctor's offices in primary care settings. So we treat all the patients basically in the same way, unless it's allergical or have different situations. Otherwise, most patients are treated in the same way. And apart from that, the evidence-based protocol to guide the treatment management in primary health care. And another important part is the system for monitoring. Here is the HAS pack, for the HAS package we used in China. So with this monitoring system included, the validated devices, blood pressure, for blood sugar and the lipids profile, and all these systems is automatically measured, automatically transferred to the, to the whole system on the website. The whole world can see it, but only for the registered doctors with their password can see it. And no matter where the patient is, the doctors use their password to manage these patients. So this system can be used for screening the patient, for registration, for risk assessment, because measured all the risk factors, we can do the risk assessment and help the clinical decision making. And also, this system can be used as a recall and a reminding for the patient to come back for the follow-up visit. So the system used for monitoring, but also for the management of the hypertensive patients. So how the system monitor the quality of care? So with the recording the patients, the measures, the prescriptions, and visit, the reassessment of blood pressure, we can know the quality, and also if the patient doctors titration the dosage, and also change the medication if the patient not achieve the target or refer to the hospitals. So we monitor the quality of care and the population coverage. So we know how many patients are measured, how many patients are treated, and how many people achieve the the targets. So basically the quality and the coverage fully monitored by the system. And we report the daily, weekly, monthly, and yearly performance of care providers, means doctors, nurses, pharmacists, and public health staff, their team workers. We report their performance to health authorities and primary care services. So we know everyone, patient know everyone performance, and the health services, the health authority also know the performance. Here's the system. Here is the poster for standard measurement of blood pressure. And to promote, and also to scale up the hypertension control globally. So after 1 year's implementation of HAS technical package globally, the World Hypertension League issued the call to action for prevention and control of high blood pressure in 2019 in São Paulo, Brazil, to call to work with our colleagues, all partners globally, and I think the Pakistan Hypertension Society also included. So to work together with their support, we issued these call to actions to help improve hypertension control globally. We called on healthcare professionals and partner organizations to undertake the following actions: advanced management, control, and prevention of high blood pressure globally. The first is follow the best practices. For example, HAS technical package should be implemented in every healthcare services in primary care settings, and engage primary care. We should be very sure the primary healthcare providers are central hypertension control strategies, because so many patients, they are the closest healthcare providers and professionals. So primary healthcare, they are the central. to the hypertension control strategies everywhere, every country. And also we need to empower patients, not only the healthcare professionals, but also patients need to care about themselves. So we need to educate and support patients for health lifestyles and compliance to treatment. This is very important. And we also recognize and reward those for the excellent award for champions projects and organizations for dedicated to hypertension control in all population levels. That's our annual WHL or WHO Excellence Award, and also ISH provided this Excellence Award for individuals, for projects, and also for organizations to set up the great examples and get many people to follow their steps. We should also try our best to activate the policymakers for promotion of health policies. From previous discussions, I'm very happy to recognize that so many experts emphasize the health lifestyles, not only the medications, the drugs. So the policies, the health policymakers should promote policies that promote health lifestyle, health diets, facilitate physical activities. Otherwise, you only call them to do the physical activity, but not provide the environment and the facility. That's not impossible to practice. And reduce the sodium intake, use the taxes, prices, and all other regulations to help to reduce sodium, and decrease alcohol consumption, eliminate tobacco use and artificial trans fat. This is very important health diet and lifestyles, to help to prevent hypertension and other NCDs, and also to promote health that ensure the sale and the use of validated automated blood pressure devices. This is currently a global issue. More than 80% of the blood pressure measurement devices are not validated, used by the health services or individuals globally. And also the government should update national drug formularies to ensure the availability and affordability of high quality antihypertensive medications, with special emphasis on long-acting and single pill combination medicines to increase the compliance and improve the control rate for people under the treatment. We also call to activate healthcare organization societies to speed up the scale of quality care for prevention and control of hypertension. The first thing is the regular training and the certification for healthcare professionals. And also those who regularly assess blood pressure and not necessarily nurses or medical professionals, but they help the regular assessment of blood pressures. So the PAHO and WHL and our partners, we developed the certificate training course. We need to be retraining every 6 months to make sure their performance in blood pressure measurement, in the correct way and get the accurate results. And also we promote the team-based patient-centered care to make the care more, convenient, affordable, and high quality, and also team-based, because not only the physicians, but also nurses, public health staff, pharmacists, and whoever, trained and certified should join the teamwork to help the patients. And we should also use the hypertension registration public screening programs. Most of these programs only register and only screen measured and published. But use this system, we can get in the patient already measured, already know they have hypertension, and they bring them into the treatment and help them get blood pressure under control. As we mentioned, apart from the global overall situations not satisfied for hypertension control, the situation in Africa is specifically variable. So we are going to publish this call to action on hypertension control for Africa specifically. We call for African countries to accelerate the implementation of all necessary changes in healthcare management to enhance detection and treatment of hypertension, use the single pill combination as many as possible, and the implementation of home-based monitoring, and make a patient care and carry their own blood pressure and compliant treatment, and make the mobile solutions available as much as possible, specifically in the COVID-19 pandemic period, and the patient cannot travel or moving around easily. So the mobile solutions to help the diagnosis, help the monitoring, and also delivery the drugs is very important things to be used. And the step-down care, not only the professionals, physicians, we're trying to encourage the nurses and pharmacists after the training and certificate, join the work for prescription and continued care. And the government should reduce the cost of drugs, make it affordable for most of the patients, and also the availability of cheap but accurate blood pressure measurement. Monitoring devices is very important, specifically for we do not have the manpower to take care of everyone, but the cheaper and accurate devices make our job can be more efficient to get more people controlled. Lost the power. And also we call to action, this call to action for Africa hypertension control, we have 3 important goals to be achieved by 2030. First, we try our best to encourage our colleagues from Africa countries and the government and the patients to help to achieve 80% of adults with high blood pressure in Africa are diagnosed. This currently haven't achieved by most of the the regions in the world yet. And getting 8% of a diagnosed hypertensive patient can be getting treated. And also 80% of treated hypertensive patients getting controlled. So totally we have 80% of people know their situation, and 64 patients, total all patients get treated, and 51% of patients get controlled to the goal. As an intermediate step, by 2025, the current awareness treatment control rate should be doubled. 4 years away, we need to achieve the double in awareness from 27 to 54, the treatment from 18% to 36, and the control rate from 7 to 14. That's the average of global, respectively. That's the best we can help, and also the Africa country can help themselves for the better hypertension control and the better and health lives. So there are many resources from from WHO, from WHL, and basically available everywhere in professional websites and organizations. But here are 2 important things. Follow the implementation of the WHO Health Technical Package for the last 3 years, and the call to action for prevention control of hypertension globally in 2 years. WHO is going to issue the new guideline for treatment of hypertension this next week, Wednesday, 25th August 2021. So next Wednesday, WHO is going to issue the new guidelines with more intense treatment, screening, and diagnosis to try to improve hypertension control globally. And also WHO is going to publish the call to action to control hypertension in Africa. And we also hope can be largely improved global hypertension control everywhere. Now, thank you for your attention, and I'm waiting for the questions. Thank you.
Thank you for that very fantastic talk, Dr. Zhang, and sharing population level strategies to control hypertension. Pakistan's got a large population of 220 million individuals, and while most of our people are less than the age of 40, I think this is the time for us to kind of strike when the iron's hot, so to speak. We will go ahead and put our poll up for the post questions, and the participants are invited to go ahead and vote there. Excellent. So while our IT team works on getting the pre and post comparison done, we'll have our forum open for some discussion. Because we're running short of time, I would like our panelists that I call upon to make their comments very brief, up to a minute if they can. And then we have our chairperson to invite to conclude the session. I would like to call on Dr. Somia Iqtidar to make a few comments on the very, very nice talk given by Dr. Zhang.
Thank you very much, Professor Zainab and Professor Zhang. What an excellent talk and eye-opening, especially for middle and low-income countries where we need to prioritize on control of hypertension on a primary care setting level. So I think some of the ideas which were shared with you, we were all aware of it, but somehow we get so much busy in learning about advanced medical knowledge that we forget about the primary and the basic care of any disease. So this hearts package, I think it's a very wonderful idea, and the modules we can adopt and start from PSIM forum. And we would request World Hypertension League and World Hypertension League as well as International Society of Hypertension to collaborate in accrediting these courses for our primary care physicians that we initiate from Pakistan Society of Internal Medicine. Secondly, I really like the idea of creating awareness about the use of standardized blood pressure apparatuses, because often patient comes to you and say that they still have this concept in mind that this mercury BP apparatus are better and these automated blood pressure apparatus are somehow, not that accurate, which we need to dispel this among the masses. So I think creating an awareness about the use of standardized automated blood pressure apparatuses is the need of the hour, and we should all initiate this awareness campaign also from the PSIM forum. Along with the partners that we have in this course, like Pakistan Cardiac Society, Pakistan Hypertension League, as well at a national level. And thirdly, I really liked your idea about this starting the, sorry, I just forgot. I think I wrote on the chat as well. Or maybe I just forgot. But I think, about the hypertension champions, like rewarding the physicians who are doing some work related to hypertension. You would be glad to know that we have initiated the Pakistan Society of Internal Medicine Research Awards for our young physicians, which is very well taken by the residents. And we had more than 100 entries this year in our conference. And some of the topics were obviously related to cardiovascular disease and hypertension as well. So initiating this, something which is a rewarding, like honoring them with the Physician of the Year in hypertension or some research initiative, I think it's a wonderful idea. This we would also like to take up and would request you to collaborate with us to bring it to an international level thing later on. So thank you, Professor Zhang, for sparing time for us today. And it was a delight to listen to you. Thank you.
Thank you.
Thank you, Dr. Somia and Dr. Zhang. I think you got your ask from Pakistan right there. I would next like to ask Dr. Azizur Rahman to make some very brief comments, please.
Thank you very much. I think I would take this opportunity to thank our foreign speakers, Dr. Umar Farooq, for a wonderful talk on new devices, new technology. I think we can see the problems in this technology, but at least there's some hope for those who do not respond to all available oral therapies. And then I'm very grateful to Professor Zhang for her very practical talk and very applicable. And we must, I think, realize that a lot of things can still be done before we wait for the new technology. A lot of things can be done. And many speakers have said again and again that hypertension remains the single modifiable risk factor for cardiovascular disease and mortality. And by improving our counseling technique, adherence technique, by availability of cheap drugs and improving compliance, I think we can prevent deaths. So I will also take this opportunity for a wonderful moderation by Professor Zainab Samad. So I thank all the panelists and everybody. Thank you very much.
Thank you, Dr. Azizur Rahman. I'm going to call on Dr. Bilal Muhyiddin. He's got his hand up. So very brief comments, please. Thank you, Dr. Bilal.
Thank you, Dr. Zhang. Indeed, a presentation par excellence. My two comments and questions, if possible. Currently, this validation bit about the BP apparatus is extremely important. And the new idea that we have to go mercury-free actually takes us towards these BP apparatuses, which are digitalized and they are not always validated. So my request to the World Heart is basically that you need to start going out and validating these models and try and make them as cheap as possible. Sort of really like make them like for $1 each. You see, these have to be treated like as if they are the glucometers and everyone must have it. And if you can do that, that will help a lot of patients over here all around the world, the African world, whichever world you want to be, because then a BP apparatus which is validated by an international society will be available. And then you have to give the guidelines regarding how to use that, and that can follow on later on. Another thing that I would like to put your mind through, since China is normally very, very good in getting mass work done. So you see, currently you walk into a marketplace and if you're not wearing a mask, you are asked not to enter. Similarly, they check your temperature over there. So what would be your take that if in all the clinics, no matter for whatever reason you are going, it's like having a weighing scale over there that you must get your blood pressure recorded. And if this can be done, probably the mask screening of awareness, and even in the marketplace, this may be a possibility. Thank you.
Great comment. Thank you. That's the we're trying to do for people, for the places we have the heart projects. Everyone working, no matter you come for see doctors or just bring your children for the vaccination, no matter whatever reason you're getting into the clinics, you have to measure blood pressure and record it and transfer it. So for that reason, you can find the patients as soon as possible and start the treatment. Thank you.
Fantastic. Thank you very much, Dr. Zhang. I would like to make a comment that the HARS technical package needs to recognize the gender issue. ARBs are generally recommended as a second line strategy, but in a lot of different low income countries, women aren't on birth control pills or have any actual means of contraception. And so I think that needs to be recognized and included in those points need to be included in the package. But from a population level, excellent strategy, and I think that's what needs to be done in Pakistan. We've got our poll comparisons up, and if IT can put those up, and Dr. Zhang, please feel free to make comments on every single slide as we go through these.
Thank you very much. I think it's excellent, actually, because none of this is not important, but among the key, the key components of HARS package, screening for chronic disease usually is not, widely performed by the primary healthcare settings, specifically in the low middle income countries for diagnosis, heart disease, stroke, all other complicated diseases need, devices, you need instrument, need some specialists. So it's not, we do screen risk factors, but not screening for chronic disease. It's a little more expensive and complicated for the hypertension control project. Yeah, we do hope we can do that if, you have the situation. So most people kindly indicated by risk assessment here is very practically and practically only 10% of included because it's complicated. You need laboratory tests or at least you have the BMI, you have the history of disease, the smoking and lipids. Otherwise, it's difficult to accurately measurement. I'm very happy for the result. Thank you. And here is we can see the improvement the primary healthcare service is definitely the center of hypertension control, because we need a simple and standardized and need a high coverage. So primary healthcare services is correctly and the very beginning they know it, pre-test to post-test, they are very correctly recognize these important things. Thank you. And for these questions, for those without chronic disease, so we focus on 140, 90. This is very correctly understand and improved for the after the lecture. I'm very proud of you. Thank you. Wow, more people like more hospitals. If we put this as a highest priority, definitely is a correct answers. We improved from 65% to 82%. Why is not a high priority? We can't waiting for that day. We definitely like the large hospital and high level experts, but for hypertension control, it's not a high priority. Otherwise, we can't wait in that long. So thank you for everyone, and more than 80% to get the correct answer. Thank you.
Thank you, Dr. Zhang. That was fantastic. And I think clearly showed that the audience were engaged and listening to you, which is what's reflected in the poll results. Finally, I would just like to thank the speakers for fantastic talks, really, today in the second last module for the hypertension course. And would like to actually invite our chairperson, Dr. Bikaram Devrajani, who's the Vice Chancellor at Liaquat University of Medical and Health Sciences. He is a strong proponent of NCD control and has worked and volunteered his time with several societies around that topic in Pakistan. He is an author for several manuscripts, editorial boards for several journals across the globe, and has done a great deal of work in building capacity at the primary care level in terms of controlling the NCD epidemic. So over to you, Dr. Bikaram, for any concluding and final remarks. Thank you very much to the speakers.
Thank you very much, Professor Zainab Samad, for inviting me. I must appreciate both the foreign speakers, Professor Umar Farooq, for nice talk, and he has given us the idea what we have to do for the renal denervation in our institutes. I was thinking that we have got interventional cardiology, and what type of research we can plan and we can go for this. So thank you for opening our mind to think on this side. And for the next speaker, Professor Zhang, she has given very nice talk for the primary healthcare and for even for we senior people to make the policies. And I'm 100% agree with Professor Bilal that it should be mandatory for every primary healthcare to take the blood pressure of every person, whatever the disease he's having. He visit the clinics. They must have a blood pressure screening, and we should have a calibrated blood pressure apparatus so that we can take the exact data and we can do the we detect the hypertension very earlier. And Professor Aziz Rahman, I am very thankful to you that you have gone through this hypertension course, and you have really done the wonderful job, because this is a common problem. Hypertension is a common problem. So so you have taken the lead, and I also appreciate the Dr. Somia that she might be thinking about to plan a few research projects from primary healthcare. So we will do it. And for the primary healthcare physicians, I would like to say them that please check the blood pressure of the patient. This is mandatory. But if patient having the comorbidity and then please and having the hypertension, then please refer this patient to a specialist, because sometimes it may be too late. Sometimes we receive the patient with renal disease, so hypertension with the anemia. This is definitely indicating the renal disease. So please refer this patient earlier. And also the endocrine disorder, which those are common in our country, particularly not the renal disease, but particularly the thyroid disease, hypothyroidism, hyperthyroidism. They are treating them, and then they are doing this thing. Another thing, if any patient having the hypertension, you must look for the blood sugar, because most of them, they are diabetics. And in our national survey of diabetes in 16-17, I was one of the partner, that we have 40% of our population of Pakistan is having the metabolic, some of the metabolic disorder, and 26% population is having the diabetes. So please don't ignore the taking the blood sugar in these patients. And I am highly thankful to the Professor Zeng. Professor Zeng, for your knowledge, our university is collaborated with the Shanghai Medical University, and also the Nanjing Medical University. With the Nanjing Medical University, we are working on arsenic and health research, and I am the vice chair of that Asian Consortium for Arsenic, and for that. So we will love to have this collaboration, different collaboration with you people as well, with the Beijing people. And I'm thankful to our president of the Pakistan Society of Internal Medicine, Professor Javed Akram, and our Secretary General, Dr. Somia Iqtidar, that they have really gathered all the internists in the Pakistan, and this program is they are doing wonder, and I assure them that I'm their soldier. I can work in the community, and because our university is in the periphery, not in Karachi. So and we have already established a very good relationship with the primary physicians. We have started the diploma in family health care from 2015. So we are enrolling the general practitioners, because we were knowing that general practitioners, they are busy in their practice and their knowledge is not going to be updated because they are working in periphery. So through this IT services, we can update their knowledge, and so we will do it. And definitely, Dr. Somia, we will do both the things. We will do the screening, and we will also do the research in the periphery. By sitting in our offices, we can guide the primary physicians to take this care of. And thank you again. Thanks to everybody for this nice involving me in this great session and very common topic. Thank you very much. I am also thankful to Professor Shabir Qureshi Saab, Shahbaz Qureshi Saab, that he is senior to us, and he might be. I met him in some of the conferences, but there was no direct link with him. But he is the man of the man of commitment, and he's always with us, and he always encouraged we youngsters to do the things. Thank you very much. Thank you, everybody. Thank you.
Thank you so much, Dr. Devrajani, for those concluding remarks. Finally, again, I would like to thank our speakers, Dr. Umar Farooq, Dr. Zhang, for taking our time and sharing really important insights on these topics today with us. I would like to point out to the audience that the final module of the Hypertension Course 2021 is going to be aired on 5th September, and will feature Dr. Azizur Rahman, who will be providing you with a summary of all the other topics and lectures that have been covered so far, and Dr. Javed Akram, who will be talking about the state of art lecture, hypertension and beyond on that specific day. So don't miss it. And thank you everybody for participating. I would like to also thank the corporate partners at Collabs who really helped us in organizing the sessions and getting this done smoothly today and with other modules. So thank you very much. Over to Dr. Azizur Rahman for any final remarks.
Thank you very much. I think we now must conclude. Everybody must be getting late. So it was a wonderful experience, this session too. Thank you. And if I may say, if you may ask, so when we talk about goals, we emphasize to achieve certain goals, but missing the goal is not like missing the train or missing the flight. So those who are unable to achieve the precise goal, they still get benefit. So we must keep trying them to get as much close to the goal as possible. Thank you.
Bye, everyone.
Hi.
Thank you. Allah
Very
Hafiz.
good job, Zainab. Very good job.
Bye.
done.